I mean, in the sense like we have around 85 questions, like from both sessions combined. So like almost like 35 to 40 in first session and 35 to 40 in the second session. So it's been a kind of a huge task compiling all the questions, but I've tried my best to get questions from some people. So let us try and finish off as soon as possible. I think the first question was the beta blocker that was asked in heart failure. There was, I mean, 4 questions were there. I mean, 4 options were there: bisoprolol, labetalol, and then they have given propranolol also, if I'm not wrong. So the answer will be bisoprolol for that. Simple, because there are only 3 beta blockers that are found out to be effective in heart failure, right? One is bisoprolol, metoprolol, and carvedilol. So the answer for that will be bisoprolol. And they've asked about the type 1 diabetes and stage 3 beta cell dysfunction, right? So they're specifically given that stage 3, if I'm not wrong, they've given specifically stage 3. So in the stage 3, what you're going to see is like definitely if it's going to be a type 1, you're going to have autoimmunity positive, antibodies will be positive. And in stage 1, patients will not be symptomatic. And there will be like beta cell destruction going on, but patient will not be symptomatic and the glucose levels also will be normal. So this will be kind of stage 1 picture. And dysglycemic pre-symptomatic is stage 2 picture, but dysglycemic and symptomatic is going to be the stage 3 picture. So if you ask me what do you mean by stage 3, patients will be having autoimmunity positivity, that is antibodies will be positive, patients will be dysglycemic, and patients will be symptomatic as well. So this is what we generally call it as stage 3. So the right answer for this question will be option B, obviously. I think there was one question with regards to the tall T waves that was given in the ECG, and answer for that was hyperkalemia, right? Hyperkalemia. So that was there. Yeah. And apart from that, there was another question with regards to ventricular tachycardia. They asked like something to defibrillate, continuous CPR, check pulse. I think this was a question that was discussed by Jani ma'am. I'm not exactly sure about what question was this. So let us skip this for now. We'll discuss that later on. I think there was an arrange in order kind of a question. 4 ECGs were given, like one of flutter, another is fibrillation. Then we have PSVT, then we have the VTAC. So they asked you to arrange all the 4 questions in order and 4 ECGs in order. So that was one question. I think one of the ABG question. Okay, larger screen, text are visible. If you can zoom. Yeah, I will try to zoom in. Yeah, I'm zooming in even further. Yeah, fine. So there was a question with regards to some simple ABG question. It was HAGMA, right? So that is high anion gap metabolic acidosis question. So they also gave something with regards to pancytopenia. Can you guys help me with what exact pancytopenia was it? And they asked what is the treatment, whether it's IVIG or doxorubicin or radiotherapy, lymph node or steroid and vincristine. So what is the exact therapy, exact question of this? Metabolic acidosis with compensatory respiratory alkalosis and high anion gap. Yeah, that's a simple HAGMA question. Yes. So what was this question all about? Just I'm curious. That's what I'm asking. What was this question? There was a pancytopenia. Okay, TLC raised. Okay, it's not pancytopenia. Okay. Platelets were low. TLC were raised. HB7. Okay, thank you so much for your inputs. TLC raised and platelets around 60K. Lymph node and spleen. Lymph node, spleen, positive. So CT with vincristine, IVIG for 2 days. Yeah, this is paper 1. Yeah, that's correct. Management asked. So it's an ITP. ITP cannot have anemia and ITP cannot have lymph node and spleen. Impossible. WBC is 50K. Okay. So this cannot be ITP. Impossible. So vincristine, prednisolone. Okay. Are you thinking about in terms of ALL, that is acute lymphoblastic leukemia? Child, okay. Now you're getting into the zone. Yes, it must be ALL then. Perfect. Okay, vincristine plus prednisolone. So this must be the better answer because generally we go for a regime called VPDA regime, right? Okay, cool. So we are talking about ALL, acute lymphoblastic leukemia. Okay, fine. So this must be the answer then. So we are actually talking about a VPDA regime. Fine. Good. Nice one. Nice recall. Thank you so much. Okay, let us move on to the next one. So was this an HOCM myocyte disarray image by any chance? Anywhere? So has they given any myocyte disarray? So are these both questions a single question or different question, by the way? Both these questions. So there are two HOCM questions or only one HOCM question? 8 and 9 same question. Okay, all right. Athlete. Okay. So the diagnosis was HOCM. Perfect. Diagnosis was HOCM. Hypertrophic obstetric cardiomyopathy. Yes, I'll get the questions later on. All right. It's in the same question. Are you guys wanting to do something with that of your this question? Any modifications in this question? Anything, any crucial information for this question? The seventh one? Any other crucial info you guys want to mention with regards to seventh question with regards to options? Because somebody's still uh, commenting on that. So, I mean, we made a diagnosis. This is a case of ALL. There's no doubt about that. It is acute lymphoblastic leukemia. And they have given IVIG, doxorubicin, radiotherapy, steroids, and vincristine, right? Why not doxo and dono? We don't use doxorubicin and donorubicin together, right? No, we don't use doxo and donorubicin together at the same time. So typically in ALL, the usual treatment that they tend to straight away start with is like steroids and vincristine. All right. Purpura was there. Okay, fine. Great. Good input. Purpura was there. Okay, so still the answer remains, I feel like it's prednisolone plus vincristine. So let us move on to the next one. I think there was a question on any BCR-ABL defect like CML, something like that. I mean, I'm not very sure about the first. I mean, what people told about the first shift is first shift, they're not able to recall because the questions were quite lengthy, it seems. So that's why like first shift, it's really, really difficult. And the second shift, at least the guys did have some time to describe. But first shift guys didn't have that much of a time. They hardly had the crucial 3 hours time, so we couldn't recall much. So this was a path slide. There was no BCR-ABL defect. It was Burkitt's. It was CML. Okay. Okay. All right. No question on CML. Okay. 922 translocation, BCR-ABL. Wow. Okay. This is a shift one. The first shift is what we're talking about. Yeah. First shift questions. Perfect. Yes. It's first shift. So was this question on APML or was this question on BCR-ABL 922? This was an APML question. Okay. This is the last session, of course. Medicine will be the last. Don't worry. But can you give me, that's why I'm taking a bit slow. Can you give me a bit of insights on it? What question was exactly that you're dealing with? Yeah, medicine is the last. Okay, PML RARA. Did we really have a different PML RARA question? Like, or it was a CML and PML RARA separate? Did we have two questions? One question was on Burkitt's, CD markers were there. Okay, all right. I'll put the 9th question. So Burkitt's, CD markers were there. Thank you very much. Burkitt's, CD markers were there. Okay, I'll talk about that question later on. A different question. Child hepatosplenomegaly, anemia, that's a different question. CML. Okay, APML is also a different question. All right. So we have a separate APML question as well. Okay. PML RARA one option, BCR ABL another option. BCR ABL. Yeah, I'll do it fast, please. I mean, the shift one only, like I'm struggling with the question. That's why I'm asking the questions from shift one. Shift two, I think it will be a little faster. Don't worry about it. Maybe I'll take hardly another 10 minutes, please. But just help me with the questions. ALL, AML, CML. All different questions. Perfect. So this is an ALL question. This is an APML question. Okay, all right. So this is a CML question separate. Okay, Burkitt's were also there. Okay, all right. Okay. So can you help me with the AML question? So what was the AML question? Okay, oil rods and marrow. AML RARA translocation was the answer. Oil rods and marrow. It is PML RARA was the answer. Cool. Another question, T922, child means it must be a ALL. If it's a child, it's not CML. CML doesn't occur in children. If you see T922, child, it must be ALL. Because Philadelphia positivity is very common in children with ALL. Okay, DIC with low platelets. DIC picture with low platelets. Thank you. Good clue. Plus oil rods and marrow. Perfect. Thank you. Thank you so much. Thank you. Thank you. Thank you. So what, I mean, just let us move on. This is the CML question. So what is the CML question, by the way? CML question, they ask the T922 translocation separately. Where are they asking the T922 translocation? This is not CML. This question is Burkitt's question. Okay, fine. So let us, yeah, T922. Okay. Okay, cool. So let us leave it. Burkitt had an image. This is a separate question in the options. Yes, BCR ABL T922. Okay, anemia, protosplenomegaly, WBC 40K. Okay, all right. Fine, let us move on to the 11th question. Thyroid eye disease false statement can lead to vision loss. Response to ophthalmologic symptoms is adjuvant to thyrotoxic response, no specs, classification, and 10% have eye involvement with euthyroidism. TDT negative, CD34 negative, CD3 negative, and CD19 and 20 positive. Okay. Thank you so much for the input again. Question, there were neutrophils. Okay, we'll discuss about that question later on, guys. So once we have finished all these things, we'll come back to that question again, maybe at the end, maybe for 5-10 minutes. So thyroid eye disease false statement can lead to vision loss. Response to ophthalmologic symptoms is an adjuvant response to thyrotoxicosis response. Then no specs classification is used. Then 10% can have eye involvement with euthyroid status. So what is the answer for this? Is the question right? Because they're asking which is not correct, with the false statement. Okay, leave that question, guys. We'll come back to that question. Like, help me with the thyrotoxicosis question. Thyroid short status not proportional to the treatment. Thyrotoxicosis response one was the incorrect. That's correct. So this is the incorrect statement because even if you give whatever anti-thyroid drugs that you're supposed to give, your ophthalmologic status will not respond to it, right? So your treatment will be Dexamethasone, steroids. Yeah. So correct. So there was a question on star of death, if you remember. So that's basically subarachnoid hemorrhage if you wish to. No? There was a question, right? Star of death, a CT image. So I think it was subarachnoid hemorrhage, if I'm not wrong. CT angio also was given. Was this first shift or second shift question? Okay. All right. There was no question on Pancoast tumor. Thank you. So I think they asked like the ptosis in Horner syndrome is due to Muller's muscle. So that one is easy one. So that's fine. That's all right. So subarachnoid hemorrhage was there. And there was a question on bedaquiline indication for bedaquiline on MDR TB. There was a question like that. So you have to use bedaquiline only in MDR TB. Okay, subarachnoid hemorrhage with berry aneurysm, first shift. Okay. Seen on CT angio. Chronic STH. Okay, I removed the Pancoast tumor, all right. Okay, all right. So what is the question on thymoma? Can somebody say? So what question was asked on thymoma? Thymoma and myasthenia gravis. There was a question on Samter's triad as well. All right. Okay. Short course bedaquiline in MDR and rifampicin resistant TB indication. Samter's triad is something that's seen in aspirin exacerbated respiratory disease. It's a triad of nasal polyposis, aspirin hypersensitivity, and asthma. Rifampicin, INH resistance, rifampicin. So basically, we are talking about MDR, right? So no matter what, let us don't waste time. So it's an MDR TB. I think in multiple myeloma, herpes zoster reactivation is seen with bortezomib, right? So that was a question that was asked. Okay. Myasthenia gravis, CT chest anterior mediastinal lesion. Oh, wow. Cool. Myasthenia gravis with CT chest showing anterior mediastinal mass. C equal to thymoma. Perfect, easy one. So Samter's triad, aspirin hypersensitivity is due to metabolites other than COX-1 inhibitors or only aspirin. Aspirin hypersensitivity is basically due to COX-1 inhibitors, right? Any COX-1 inhibitor, it's not just aspirin. Can you hear me, guys? Yeah, I'll go fast. Don't worry about it. I just want some questions. No, I just want to know whether you're able to hear and see me because there was no power here. I mean, we're just running in the backup generator. Okay, all right. So the sample triad question is all about not only aspirin, it's about aspirin and other drugs as well. Thank you. Aspirin and other COX inhibitors. Okay, thank you. So they have been given a question on multiple myeloma. I think the patient had a neuropathy and patient had polyuria, patient had weight loss. I think the answer for that was amyloidosis, if I'm not wrong. Isn't it? The answer was amyloidosis. Multiple myeloma, patient had tingling sensation neuropathy, and patient had polyuria, that is because of hypercalcemia, and patient did have weight loss, which is basically a feature of a cancer, and answer for that question was amyloidosis. Perfect. Okay. So then we had alcoholic patient with hypoglycemia. I think the CBG was somewhere around 49, if I'm not wrong, 49 millimeters of mercury. And I think the answer for that is, of course, in any alcoholic who's with altered mental status, unconsciousness, altered mental status, you have to give thiamine first, followed by dextrose. All right. And there was a question on farmer who came with intense calf pain. I think it's lepto. Like whenever they say calf pain with severe back pain, that is so characteristic of leptospirosis. Right. I mean, I'm not very sure exactly what differential diagnosis they give. I'm not very sure, but I think farmer, right? They're very prone for leptospirosis. I feel it's still leptospirosis. Omelette question was not there in the first shift. Okay, I'll remove it. I don't know, but somebody really said this question was there. There was a question. Uh, there was a question, if I'm not wrong. This question, I think like in the first shift, guys did ask this question. There was some peripheral neuropathy. I mean, the options were like subacute combined degeneration of the spinal cord with diabetes, subacute combined degeneration of the cord because of B12 deficiency. There is some question like that, if I'm not wrong, because I clearly know that some guys have asked this question. Okay, I mean, I'm literally sure about this because some guys did ask this question. Okay, the multiple myeloma is different, but there was a question on somebody who came with tingling sensation in the legs, polyuria, weight loss. Options were a subacute combined degeneration of the cord with diabetes, subacute combined degeneration of the cord with B12 deficiency. And one of the question was, yeah, image, there is left shift, neuropathy, polyuria, weight loss. Okay, the answer is only multiple myeloma. Perfect. Thank you, thank you, thank you, thank you, thank you. The right answer is multiple myeloma with renal involvement. Okay, all right. Thank you so much. And this is surely leptoman. This is calf pain. I mean, if you have not watched my tropical infections class, uh, I mean, you might, I mean, anyone who's there who has watched the tropical infections class, where I've given a summary of all the tropical infections, if I'm not wrong, anyone? You will clearly know that. How much times I emphasize that calf and back pain point. Leptospirosis is something that tends to produce that intense calf and back pain very commonly. So this is lepto for sure, without a doubt. I think there was a question of acute rheumatic fever. Tingling sensation question. I mean, somebody's Bhumika is telling tingling sensation with answer is SACD. Remember, if it's a tingling sensation, why the patient should have, if it's SACD, why the patient should have polyuria and weight loss? I mean, just let me know. Like if it's tingling sensation with, I mean, there is polyuria and weight loss, why that should happen in B12 deficiency, by the way. No. So that must be multiple myeloma with renal involvement. It's impossible. That other features doesn't correlate with just a simple subacute combined injection of the cord. Okay, there was a question about this acute rheumatic fever, some joint pain, uh, like with mitral regurgitation, pansystolic murmur was heard. I think it was a case of acute rheumatic fever. So it's an easy one. It's a simple one. Acute rheumatic fever. Okay. All right. So young, high fever, rheumatoid factor negative, pansystolic murmur. Okay. 18 years. Perfect. Thank you. I'll update it. 18 years, high fever, RA negative, RF negative, plus pansystolic. Yeah. Sorry. Sorry. A power failure. So I think here there is like there's some problem with the power. It's keeping on going and coming. So just hold on with me. So RF negative. So it's an acute rheumatic fever. So there was a question on blackish discoloration of the lips, and there was adrenal insufficiency. Knuckle hyperpigmentation also was mentioned. Okay, patient was a female. I'm not very sure about what they're trying to say with this question, but around the lips, black discoloration, very likely to be adrenal insufficiency. Okay. Okay, all right. There was Light's criteria on pleural tuberculosis, if I'm not wrong. Light's criteria on pleural TB. So it was an X-rate, right? So the LDH ratio was, I think, more than 0.6, the serum LDH. Okay. Okay. I think the pleural fluid LDH to serum LDH was more than 0.6, more than 60%. Fluid to serum LDH was more than 60%, more than 0.6. Okay. All right. Other things were transudate. Okay, fine. We'll talk about that. Anyway, it's a Light's criteria positive. It's an X-ray, it's a straightforward one. Okay, fine. All right. So there was a question, right? Patient present with chest pain, shortness of breath, elevated jugular venous pressure, deep wide descent. Okay, then diastolic sound, that is nothing but the pericardial knock. So I think it's a constrictive pericarditis. That was the answer. That was the diagnosis. It's a straightforward one. So patient had chest pain, shortness of breath, elevated JVP, deep wide descent, a diastolic sound. Yeah, diastolic. Irregular rhythm was there in the option. Bicuspid valve with AR, rheumatic arthritis, MS, constrictive pericarditis. It's a diastolic murmur or a diastolic sound, by the way. Diastolic murmur or a diastolic sound? Patient has edema also. Okay, so this is the ambiguity, right? We don't know whether it is sound or whether it is mama. Not sure. It's a diastolic sound. Perfect. Then it's very clear. So it must be pericardial knock, and it confirms it's pericarditis, constitutive pericarditis. And there was a question on hypophosphatemic rickets, right? Hypophosphatemic rickets, if I'm not wrong. So I think the calcium was normal. Calcium normal, only phosphorus was low. Phosphorus low. So that was an hypophosphatemic rickets. Okay, that's done. So it's a rickets, but it's not hypocalcemic traditional vitamin D sensitive rickets. It's hypophosphatemic rickets. All right. What was this question, guys? I mean, before going to second shift, what was this question? What was this question? What was this one? The albuterol question on asthma. So there was a question on asthma, and they've been talking about albuterol, and patient was already on albuterol. Okay. ALP high, ETH normal. Okay. All right. So what is this question on albuterol? The patient had asthma, patient was on albuterol inhaler. What was exactly given? I'll come back to the caffeine question, doctor. I'm not sure what exactly they were asking. I mean, we'll come back to that. What is the asthma question? What should be added? 85% improvement when taking drug, improve SpO2 on inhalational drugs, weekly symptoms. To add inhaled corticosteroids, oral steroid, LABA alone. Okay, guys, generally, what do you think? If the patient is symptomatic, if the patient is only on albuterol, what do you really think? Okay, it's better to add, right? Add inhaled corticosteroids. That's what I would say. In any asthma right now, the gold standard is like you have to add inhaled corticosteroids to treatment. Without steroids, you cannot treat asthma. Simple. So one per night in a week. Yeah, obviously I'm going to add steroids. Without steroids, you cannot treat asthma. Impossible. Okay. So symptoms were 2 per week, 1 per night. One night per week. Okay. Nighttime awakenings per week. Okay. Thank you. Add prednisolone. Yeah, I'm not going to add prednisolone. We don't add oral steroids unless until it's an exacerbation. Or maybe in very severe cases, short-term steroids can be added. Otherwise, it's only inhaled corticosteroids. Other option was only salmeterol. Even that is not recommended. See, asthma, best treatment, always add inhaled corticosteroids. As simple as that. And some guys were telling about the pulmonary hypertension question. Can you just tell me with the pulmonary hypertension question, we can move on to the shift 2? So what was the pulmonary hypertension question? I mean, maybe I'll finish off and then we'll move on. What will be the pulmonary hypertension question, by the way? Thank you so much, guys. Secondary pulmonary hypertension is due to scleroderma. Okay. Which is due to scleroderma. So that was the answer. Endothelin antagonist decreases symptoms. That's correct. That's correct. Endothelin antagonist decreases symptoms. That's correct. Calcium CCB is used as first line? No. CCB is first line? Definitely not. This is wrong. This is wrong. Unless and until the patient is having a good a good vasodilator reactivity, I'm not going to use that. SARS TCP to everyone? No. Wrong. Endothelin receptor antagonists will improve disease? No, they will only improve symptoms. Disease cannot be improved. There is no disease modifying therapy right now. CCBs to all endothelin antagonists. Antagonists improve symptoms. First line treatment is lung transplant is also wrong. Lung transplantation is also not done. It's not first line treatment. Vasoreactivity was good. Okay, lung transplant is not the first line treatment. That's also wrong. Maybe I'll go for this one. So, I mean, what is this one? Secondary pulmonary hypertension due to scleroderma. So was this a separate question, or this one was the same question? Scleroderma. Secondary pulmonary hypertension due to scleroderma. Was this a separate question, or this is a part of this question only? Systemic scleroderma, same question. Secondary pulmonary artery hypertension is due to scleroderma. So was the option correct? So was this option there in the same question? Was this the exactly same question, like secondary pulmonary artery hypertension is due to scleroderma? Okay, so it was a patient of scleroderma and pulmonary artery hypertension. Okay. Got it. Okay, got it. Okay, so answer for this question will be this one. Endothelin receptor antagonists improve symptoms. Thank you so much, guys. Thank you. Let us move on to the second shift. Okay, quick. So there was a question on atrial flutter and treatment. I don't know exactly what question. Atrial flutter and treatment. Okay, all right. This question was not there then. Okay, fine. Okay, I'll come back to that question. Okay, so PR interval more than 0.21 seconds. Answer is first degree AV block. So it's more than 0.2 seconds, it's going to be first degree AV block. It's a simple question. I think they have been asking another question on IT dissection and Stanford type B. I think they have given an image on that. So actually, this is the answer for that, because type B dissection, it's going to be more of conservative management. We're not going to go for any surgery when it comes to type 2, type B dissections. Type A only has to be operated. Type 1 need not be operated. Okay, so then they asked about which worsens murmur in hypertrophic cardiomyopathy. That was an easy one. Answer is going to be Valsalva. Easy one. We have had a mnemonic, right? Valsalva always increases. So it was equal to 0.21. Okay, equal to 0.21. So still answer is going to be remaining the same. So it's going to be first degree AV block. No doubt about that. It's still first degree AV block. Okay. Okay. All right. So there was a question on supracellular mass causing visual field defect. What visual field defect? It was, I think, bitemporal hemianopia. Doctor, we have already discussed about the Samples triad question in the beginning itself. So what was that question on supracellular? 0.21 is not normal, doctor. 0.12 to 0.2 is normal. Anything more than 0.2 is first degree AV block. Worsen means, yes, increase. Worsens. Worsens means increase, mama. Correct. Yeah, it is bitemporal hemianopia. Thank you. Hemianopia. Okay. So there was a question on sweating, macroglossia, frontal bossing. What is the initial investigation of choice? Initial is what they're asking. Easy screening with IGF, right? So there was a question on that. So the patient had macroglossia, frontal bossing, like suggestive of acromegaly. I think initial investigation, screening, of course, it's IGF-1. Okay, so this is the question that everyone was asking. The most common cause of death in idiopathic pulmonary fibrosis. Answer is respiratory failure. Simple, easy one. It can't be anything else. It must be respiratory failure because the most common cause of death in IPF or any primary lung disease is death due to that lung disease itself. That's why they die. So maybe if they ask about COPD, it's going to be the same. So die of respiratory failure. So die of the primary lung problem itself. It's not pulmonary artery hypertension. Okay, gap between incisors is seen. Okay. Also has gap between incisors. Okay, all right. Supracellular mass. This is a craniopharyngioma according to certain people's input. Craniopharyngioma. All right. I'll be okay with that. Okay, fine. One second. Okay, so there was a case of tamponade. No. There was a power failure here, guys. Like it's keeping on going, coming for some reason. I don't know. It's happening today for some reason. It doesn't really happen, but for some reason it's keeping on happening. Sorry. Okay, I will come back to that question, guys, in a while. It's there. So this was a tamponade question and answer is pericardiocentesis. So patient had cardiomegaly, diastolic RARV collapse. X-ray image is suggestive of, I think, effusion, pericardial effusion. Diastolic RARV collapse. Patient is having shortness of breath. Heart rate is 120 per minute. BP is 130/90. So this must be diastolic RARV collapse. Eighth question. Yeah, sorry. I think this is a simple iron deficiency anemia, if I'm not wrong. It's a very easy question. Simple iron deficiency anemia. Right? So low hemoglobin, low MCV and MCH, low serum iron, reduced transferrin, high TIBC. So this must be an iron deficiency anemia. So they given diuretics. Diuretics was not correct. So you cannot use diuretics in tamponade. Already patient will be having reduced RARV filling. If you're going to use diuretics in in tamponade, patient is going to get worse. It will precipitate a shock and they will die. You can't do that. So diuretics cannot be given. Yeah, RA collapse. Okay. 100% it's tamponade. Answer is pericardiocentesis. Absolutely no doubt about that. Okay, so then patient is, what spasmolytic you're going to use in IBS? What spasmolytic? I think we have some questions. Don't worry about it. We'll finish it off. So we have some spasmolytic. They've asked about what you're going to use in IBS. It's going to be dicyclomine. Okay, that's the only spasmolytic that we use in IBS patients. We don't use anything else, according to me. So scopolamine is more of motion sickness drug. And sometimes we can use for vomiting in during traveling. And atropine, we don't use it unless and until it's an OPC poisoning. So technically IBS of diarrheal type. So it must be dicyclomine. Okay, all right. So I think there was a question on myasthenia gravis. There was a question on irregular pulse treatment. Before that, was there an image on pseudomembranous colitis? Pseudomembranous colitis image was there? Was it the exact question, same question, pseudomembranous colitis? Okay, that was a question. Good, that was a correct question, right? Pseudomembranous colitis. Yeah, that's a direct question. Okay, that's an image-based question, direct one. Okay, simple. So this one, I'll come back to this later on because there is a couple of questions in this. And there was a myasthenia gravis and hypercalcemia. I think the only possible explanation for that was parathyroid adenoma. There was no possible explanation. I think they have given some small cell lung cancer. They have given adenocarcinoma. I think there's nothing else. Okay, it must be parathyroid adenoma. So, I've seen the question. According to what the students have given the input, it's just parathyroid adenoma that's fit into the picture. Nothing else fits into the picture apart from parathyroid adenoma, if I'm not wrong. Okay, there was a question on Foville syndrome. Again, if I'm not wrong, I think patient had ipsilateral 7 plus contralateral hemiparesis plus patient had horizontal gaze palsy, conjugate gaze palsy. Horizontal gaze palsy was there. So this must be Foville's because if it's going to be Millard-Gubler, it's only 6-nerve palsy. Patients do not get horizontal gaze palsy. If the question has said horizontal gaze palsy, it must be Foville's. The question has said abducens nerve palsy, it must be Millard-Gubler. If they have mentioned horizontal gaze palsy, it is Foville's, no doubt. Okay, it cannot be Millard-Gubler. We have discussed that so many times. Just ignore. Okay, so they asked AF, what is wrong? I think beta blockers and CCB is not given in heart failure. I think patient did have heart failure. So I think beta blockers and CCBs we don't give. People are commenting on Millard-Gubler. See, guys, you have to tell me the question. If they have said horizontal gaze palsy, it's done. It's Foville's. Simple. We can't diagnose Millard-Gubler there. You might think it's 6 plus 7, but horizontal gaze palsy is completely different from lateral gaze palsy. Lateral rectus palsy. Both are not the same. So IV digoxin, yes, can be given in patients with atrial fibrillation. Absolutely, yes. Okay, it's an AF case, absent AF. If it's horizontal gaze palsy, I'm telling you it is Foville's. There is nothing else you can diagnose. Simple. Leave that off. Leave that off. That question is done. Okay, so I think this was there, right? In heart failure, beta blockers. given in heart failure, something like that. Patient was having heart failure. So what is this question? I'm not very sure about it. What is this question basically? Okay, leave that question. Horizontal gas palsy, it's Powell's, it's done. Now come back to this question. AF, what is wrong? Help me with this question, guys. Atrial flutter ECG or fibrillation, whatever may be the ECG, what cannot be used? Beta blockers if CCB can't be used. I'm not very sure about it. Cardioversion if unstable, that's correct. Okay, that's a correct statement. Cardioversion if unstable. Okay. Okay, they have given AF ECG. Which of the following, what is wrong? Which of the following cannot be given? That's a correct statement. Digoxin given, what not to combine? Give digoxin. Digoxin to control ventricular rate. Digoxin to control ventricular rate is also correct. We can use digoxin if the option is correct. This is a true statement. Anticoagulant, Dovax used. Okay, this is a correct statement. What is the last one, guys? Which is incorrect. I don't know. What I mean, if you cannot tell the exact option, I cannot help with this question. Yeah, digoxin can be given in ventricular rate control. Why not? Absolutely. Even if it's IV digoxin, still we can use. Absolutely no problem. In fact, one of the standard indications for using digoxin is atrial fibrillation. Beta blockers if CCB cannot be used. Okay. Okay, this must be wrong. Because ideally what we do is we use CCBs if beta blocker cannot be used. First line is actually beta blocker. So we use CCBs if beta blocker cannot be used, not the other way around. Perfect. Yeah. So then the answer must be this one. Beta blocker if CCB cannot be used. Yeah, that's the one. So unstable cardiovert, IV digoxin to control rate is correct. DOAC can be used. Yes. Anticoagulation is a must in atrial fibrillation. And beta blocker if CCBs cannot be used is wrong because CCBs must be used only if beta, it's the other way around, if beta blockers cannot be used. So actually beta blockers are the first line treatment, not the CCBs. Patient is having heart failure. Patient is having heart failure. Then perfect. It's done. Beta blocker cannot be used at all. This 100% cannot be used. The option number 4 is totally gone if the patient is having heart failure. That's a good input. In fact, it's a tremendous, fantastic input. Doc insane. Yeah, thank you so much for your comment. I think my postgraduates believe something otherwise, actually. I think someday or other, hopefully we meet in our hospital so that we can share our knowledge. We can exchange something with you and me so that we'll understand, maybe you can teach me something. Okay, in the ECG, ventricular rate was normal. I'm not very sure about whether ventricular rate is normal or not, whatever it is. And I mean, if the patient is in heart failure, if this statement is correct, this one is wrong. Absolutely. No. Simply, I mean, people, I know about people, like it's fine, whatever they say, like I don't really matter. Okay, that's fine. That's fine. All right. So beta blocker, if CCBs cannot be used, that's wrong. Okay, so let us ignore this question and move on, because if they have given heart failure, so definitely this is a wrong statement. In heart failure, you can't like use beta blockers as well as calcium channel blockers. Okay, fine. So they have given some, we can give warfarin. Why not? We can give DOACs and we can give warfarin as well. No. I mean, don't think too much. It's IV. I mean, IV digoxin can be used for atrial fibrillation for weight control. I mean, just ignore. I mean, we are wasting way too much time on that. So what about this one, ring enhancing lesion? I think the next step that we have to do is MR spectroscopy. This one, right? It's MR spectroscopy. So there was a ring enhancing lesion. Okay. Okay. Fine. So that was an MR spectroscopy. Cool. So then there was a question on dengue. So I think the hematocrit was 55, platelet count was only 25,000, which means platelet count was reduced, hematocrit was increased, and patient had a maculopapular rash. Okay. They asked about the best prognostic marker. Answer is hematocrit. Because everything, if you look at the treatment, the warning signs, everything is all about hematocrit. Hematocrit, and hematocrit. Simple. Okay, they have given LP normal also. Simple, it's done, finish. LP normal, ring enhancing lesion. Perfect. It must be MR spectroscopy to distinguish what's going on. Whether it's a neurocysticercosis, or is there any tumor, or is there any tuberculoma. So for all these things, we can use MR spectroscopy, depending on whether it's a lipid peak or multiple amino acid peak. We can try and find out what's going on. Okay. All right. So it is hematocrit. I mean, just go and have a look at the options. I mean, just go and have a look. Whatever may be the case, the treatment or maybe the warning signs, everything is actually based on hematocrit. Everything is actually based on hematocrit. It's not based on anything else. So it's hematocrit, and hematocrit all the way. That's going to be the most important. Okay, there was another question, RTA type 1 versus type 2. I think if I'm not wrong, this patient had a bicarbonate of less than 15. This patient had a urinary pH of 9, and this patient had hypokalemia. So definitely RTA type 4 is ruled out. So very likely it must be RTA type 1. So leave the pH. Okay, it must be RTA type 1 because this patient had a severe acidosis. Severe acidosis is always a feature of type 1. Type 2 usually does not produce severe acidosis. Potassium was 2.8. Yeah, somebody was telling 2.3, but okay, fine. So whatever may be the case, it's a hypokalemia. So definitely it's not RTA type 4. So bicarbonate was 12. Okay, all right. So that strongly points towards RTA type 1 because, I mean, anion gap was 11. So that's a classic feature of any RTA. You're having a normal anion gap metabolic acidosis. Uh, so it must be type 1. Yeah, it must be type 1. Because this is the point. These 2 points I will consider a lot. This must be type 1. So the patient is having very low bicarbonate, very high urinary pH. It must be RTA type 1 because the acidosis is quite severe in patients with type 1 compared to type 2. And there were, I mean, students were telling there were 2 to 3 questions from iron deficiency anemia. So I don't know exactly what questions they have been asking in exam. So I have to like go and encourage students more about it. So what exact questions about uh, iron deficiency anemia? And there was another question that atropine plus diphenolxylate for IBS, why they are combined? Actually, it's to decrease abuse. Main reason why they are combining atropine and diphenolxylate together, because diphenolxylate has a bit of abuse potential and we don't want that abuse to happen. So that's the main reason why we give atropine together. So there's no other reason for that. Okay, so Option is 20. I mean, the answer for question number 20 is abuse decrease. In iron deficiency anemia, transferrin saturation will be low. It's an easy one. Iron deficiency anemia, transferrin saturation will be low. Simple. I think I have a question on ileal resection. Ileal resection, what is not to be seen? There was a question on that. Okay. If you want, I can add that also. Ileal resection not seen. It is microcytic hypochromic picture. Because in ileal resection, you have B12 deficiency, and that is supposed to produce only a macrocytic picture, not a microcytic picture. What happens to transferrin equivocal? Okay, I don't know. Ileal resection, what is not possible? Microcytic hypochromic picture is not possible because of the B12 deficiency. Okay, so now next question, I think in methanol poisoning, what are the things that are increasing? That's what they're asking. So I think it's basically formic acid and lactic acid. That's the right answer for that question. So in methanol poisoning, the main metabolite that causes questions is formate. Okay, and apart from that, because of the hypoperfusion to the tissues, you will result in lactic acidosis as well because of the anaerobic glycolysis. Yeah, Romberg positivity can be seen. Reversible dementia also can be seen. But what is not seen in microcytic picture? That's correct. Okay. All right. So this is the answer for methanol poisoning. I think there was a question on toss ID point. So if given with erythromycin, I think it's astimazole. So that was the first generation antihistaminic. So that is supposed to prolong the QT. And in the presence of erythromycin, obviously it's an enzyme inhibitor. The levels of astimazole increases and that can prolong the QT significantly, which can result in toss ID point, which is a life-threatening arrhythmia. Okay. All right. So then there was a question on atrial fibrillation about absent A wave. The patient had irregular rhythm. That was an easy question. It was an absent A wave. And there was a star of death image. And I think there was a CT angiogram image as well, showing a barioaneurysm. Aneurysm. I think it was subarachnoid hemorrhage from aneurysm. Right. Star of death in set 1. So this was not the case. Okay. All right. So I'll put this. Okay, it was not there. Okay. Okay, that image was there. I got it. So it was a chronic SDH, I think. Right? It was a chronic SDH image. Okay. Fine. All right. I'm removing this question. Okay. So that was not there. That was the first set. Okay. Yeah, fine. So chronic SDH, I got it. Yeah. And I think there was a question on 20 guy with coronary artery disease, tendon xanthomas, and xanthomas in the hands as well. I think it's some failure of LDL uptake, familial hypercholesterolemia. Right? Failure of LDL uptake. Right? Something like this, yeah. Achilles tendon xanthoma, yeah. It's a familial hypercholesterolemia. Okay, familial hypercholesterolemia option. This is not the question. There was no question like this. Failure of LDL uptake. Okay. All right. Okay. So this was not there. Okay. So this was the answer. Mechanism was not given. It's a direct question. Cool, guys. Okay. Okay, fine. So there was a person with history of suicidal thoughts, family found him, unknown drug, tachycardia, hypertension, sweating, palpitations, dilated pupil. Easy one, cocaine. Simple. right? Okay. All right. Sorry. And there was a question on PSVT. PSVT, pediatric patient stable vitals, what to do? So that was a question, adenosine 0.1 milligram per kilogram. That's the initial dose of adenosine. Maybe you can go up to 0.2 to 0.25 milligram per kilogram later on. It is like in adults, we give 6 plus 12 plus 12. Likewise, in children, we give 0.1, then 0.2, 0.2. It's like that. So it must be to start with, it's 0.1 milligram per kilogram. That's the initial dose of PSVT. Okay, 2-year-old boy. 2-year-old boy. Okay. Thank you so much, guys. Okay. Then I think we have discussed this so many times. This is an easy one. Solitary thyroid nodule. First investigation, TFT. Of course, we have discussed that so many times. First investigation, any thyroid disorder, suspected structural or functional thyroid disease, answer is going to be TFT. That's it. That's the first thing that we do generally. Okay. So there was another question. So I think they've given foul smelling sputum. Along with that, they have given cough. Patient was having high temperature. Chest X-ray showing air fluid level. Answer is lung abscess. Lung abscess. That's it. Okay. It's an easy one. That must be lung abscess, without a doubt. Okay, they're given sertraline plus amitriptyline overdose effects. Cipraprin. I don't know. I want to know the exact question. But nevertheless, there was another question. Abdominal pain radiating to the back. 5 days. Amylase lipase highly elevated. Okay. Amylase lipase highly elevated. Patient had clubbing. Okay. That's a good input. Yeah. Still, it's lung abscess. Plus, patient is also having clubbing. It's still lung abscess. Lung abscess. Lung abscess. Lung abscess. That's it. Empyema will be near the pleural surface. You saw the problem in the parenchyma of the lung or near the pleural surface. Where do you see the problem? If you have seen anything in the parenchyma, the center of the lung, it is lung abscess. If you have seen anything on the side, okay, on the pleural surface, it must be empyema. But I don't think anyone has seen anything on the side. They have seen exactly on the center of the lung. So that must be lung abscess with air fluid levels. ARDS not there in the option. I think then it must be non-cardiogenic pulmonary edema. I mean, that's what I want to confirm. So chest X-ray had bilateral infiltrates. So it's a non-cardiogenic pulmonary edema. So since everyone is confirming that it's parenchyma, it must be lung abscess. There's nothing else. So this is a case of non-cardiogenic pulmonary edema, which is nothing but ARDS. So this patient is having acute pancreatitis, and one of the common complications of acute pancreatitis is ARDS. Yes, ARDS was not there in the option. Okay, instead there was aspiration pneumonitis. Okay, so then your answer will be still non-cardiogenic pulmonary edema. That is nothing but ARDS. Okay, 2 liters infused. Okay, given in 24 hours. Okay, fine. So all well, all well. The answer for that is non-cardiogenic pulmonary edema. Pheochromatoma, correct statement seen in men 2A. Simple, easy one. It's not common in children. Only 10% is seen in children. Bilateral, mostly again, it's not bilateral. 10 to 15% bilateral. Highly malignant, no. Only like around 20% are malignant according to the current data. 20 to 30% maybe, but majority of them are benign. So it is seen in men 2A. Okay, so that will be the right statement with regards to pheochromocytoma. So we have discussed that already, Dr. Manas. Irregular heart rate is atrial fibrillation. JEP finding is absent A wave. Yeah, that's correct. Okay, there was a complicated question on tuberculosis preventive therapy. I'm not sure what was that question. exactly. So 3HP has more complaints than 6H. Chance of abortion with 3HP is the same as that of 6H. What was the other two options, if I'm not wrong? Dr. Mrinmoy Das. Mycophenolate and pyrostigmine was there. There was another question that was a myasthenia gravis patient with MMF and pyrostigmine. They have given hypercalcemia. Answer for that we have discussed already is parathyroid adenoma. What are this question, babe? Maybe? Okay. Wrong about 3HP treatment. Okay, less complaint. They're given less complaint. Okay. All right. Mycophenolate, mofetil, and pyrostigmine. No, I don't think they are known to cause hypercalcemia. No, no, other subjects won't be covered today. This is the last session. This is the last. So 9H or 6H is more complaint. Actually, I mean, if they ask you which is wrong, then this must be the wrong statement because this has more complaints. Okay, so patient cannot be having less complaint. This must be more complaint. Yeah, loud P2 also given, but anyway, if it's an irregular rhythm, it must be atrial fibrillation. And still it's an absent A wave only. You cannot have an A wave in patients with atrial fibrillation. So good complaint. So it was incorrect option. Okay, fine. Let us move on from this question. So answer is C for this. Okay, less complaint. And what about this one, 34th question? I think this was the same question that we have discussed already. So let me take this off. I think this is the same question. We have discussed it already. It's a tamponade. Answer is what to say? Your emergency pericardiocentesis. And I think 50-year-old male patient tearing pain in the chest, died, which means it's aortic dissection. So what's the main mechanism behind this? I think it's smooth muscle necrosis. That's the right answer. Because vasculitic inflammation is seen in vasculitis patients, fibrinous necrosis with smooth muscle hypertrophy, that is possibly seen in, again, some vasculitic conditions, and atherosclerosis is not the mechanism, smooth muscle necrosis. That is because of the cystic medial degeneration that is seen in patients with like ascending aortic aneurysms and aortic dissection. In fact, the most important mechanism of aortic dissection is cystic medial degeneration. That's basically nothing but smooth muscle necrosis. All right, I think there was an easy question on anemia, neutropenia, loss of pigmentation of skin and nails. That's depigmentation of skin and nails. Answer is copper deficiency. Easy one. So copper is something that can produce connective tissue weakness. Atherosclerosis was not there in the option. Weakness of aortic muscle. Connective tissue destruction. There was no smooth muscle necrosis. So what are the answers? I mean, then I have to rewrite this. What is the exact thing? No atherosclerosis option. Okay. All right. I'll remove that. Okay. Tropi negative. He died. Lipid infiltration and inflammation of wall. Okay. Inflammation of wall. Intimal smooth muscle proliferation. Okay. Smooth muscle necrosis. Okay. Then what else, by the way? The fourth one, connective tissue weakness. Are you sure? Connective tissue weakness. Are you sure it's there? I mean, how can it be 5 options then? Tell me the 4 options. How can it be 5 options? Connective tissue weakness was there. I mean, which option I should remove then? Okay, fibrin necrosis, smooth muscle hypertrophy. Smooth muscle hypertrophy, collagen weakness. Okay, smooth muscle hypertrophy was there. Okay. I don't know. I have absolutely no idea. Connective tissue weakness. Okay, so what else then? I mean, these are the four options. Are you comfortable with these four options? Subintimal lipid and smooth muscle. Okay, I'll go to the next question. Okay. Smooth muscle proliferation. Immune complex vasculitis. Okay, all right. Now it's complete. Sorry for the time delay. I think it's done. So now this is the final one. Smooth muscle necrosis plus lipid infiltration. Smooth muscle proliferation, lipid infiltration. Okay. Now it's the correct question. Okay, fine. So now it will be connective tissue weakness. Simple. That's all. It's artery dissection. Okay, now it becomes connective tissue weakness. Okay. Image was also there. Okay. So now it becomes simple. Okay. So because this was actually a feature of atherosclerosis, that subintimal lipid infiltration with smooth muscle hypertrophy is actually feature of atherosclerosis, right? So atherosclerosis is common in the abdominal aorta. It's not very common in the ascending aorta. It's common in the abdominal aorta. It's in the descending abdominal aorta, not in the ascending. Okay, like leave it. So let us go with this for now. So anyway, I'll collect the question if possible and let you know what is the exact answer. So it's necrosis. Okay. All right. Fine. Cool. Was written in subintimal lipid. Okay, we'll go to the next question. Okay, we'll come back to that later on if possible. Okay, so we have this one, anemia, neutropenia, loss of pigmentation of skin and nails. X-ray was given, whatever may be the X-ray. So I think this is a typical feature of copper deficiency. Perfect. This is a copper deficiency. There is no doubt about that. There's nothing else you can diagnose. There was no epithelial signs apart from this depigmentation. So this is copper. And coming back to this, old age patient, bone marrow, 22% plasma cells, T-range renal function. You have more than 3 gram like M spike, hepatomegaly and renomegaly is there. Option is amyloidosis. Because it's an AL amyloidosis, the diagnosis for this is multiple myeloma. It cannot be MGUS, monoclonal gammopathy of undetermined significance, because in MGUS, you cannot have 22% plasma cells and you cannot have deranged RFT. Okay, it's impossible. So because it's a crab feature, so it must be amyloidosis. All right. So because it's AL type of amyloidosis, that's what they're trying to ask. Okay, cool. I think this was another question. Already on HIV treatment, patient is taking zidovudin, lamivudin, nevirapine. Okay, so patient got tuberculosis. Which anti-tubercular drug to be avoided? Obviously, rifampicin, because patient is on nevirapine. So it has interactions with other enzyme inducers. So it's better to avoid rifampicin in such a case. Right. All right. So I think there was another question on severe head injury. Which of the following drug must be used? Answer is going to be mannitol. Mannitol, right? That must be the right answer. Mannitol, 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 mannitol. One with electrophoresis and one off the slide with amyloidosis. Okay, all right, that's done. ICP and headache. Woman with increased ICP and headache. It's a severe head injury, right? I mean, it's over, man. I don't know why you're telling fast, fast, fast. It's over. It's done. The 40th question was the last question. So it is mannitol. Obviously, in head injury, what we use? We use mannitol or 3% NaCl. We don't use anything else. Or sometimes DEXA if it's a vasogenic edema, but otherwise, like we generally typically go for mannitol or 3% NaCl. No, no, not astazolamide. Astazolamide is like something that's going to act like ages later. So in severe head injuries, it's an acute situation. There's no point in using astazolamide. It's only mannitol or 3% NaCl. If that was there in the option, then probably that would have created an ambiguity, but it is mannitol. Yeah, that's it. No doubt. I think they have asked about the true statement in PNH. I mean, you have to help me with this because this is definitely wrong. This is wrong for sure. So it's not inherited, it's acquired. We know that. Most common cause of death is heart failure. This is also wrong because most common cause of death is thromboembolic manifestations like Buchiari syndrome. So that's wrong as well. And flow cytometry is the gold standard. Actually, it's a true statement, but I'm little concerned about this one as well. I mean, have they given this? It's a chronic intravascular hemolysis with exacerbations. I'm not really comfortable with this. I mean, was that the exact option? No, no, it's not. I mean, mannitol is something that we give it every day in and out. It's not contraindicated. B option was not there. So what is the B option then? Sucrose lysis is useful for diagnosis. No, not correct. It's one of the screening tests. That's all. For your hereditary spherocytosis. Useful for diagnosis. No, no, flow cytometry is the gold standard. Sucrose lysis is useful for diagnosis. No, that's not correct. That's only a screening test. So flow cytometry is the gold standard. This is the correct statement. Obviously, this is the correct statement. Okay. Now you guys, I think we have completed all the 40 questions. I think I don't have any more question. You guys can ask me more questions if you want. Maybe I'll give you another 10, 15 minutes. Maybe if you want, you can ask me more questions. I mean, somebody, Ashwin Gowda is telling chronic intravascular hemolysis is frequent exacerbations. It was there or it was not there? Chronic intravascular hemolysis. Chronic intravascular hemolysis with frequent exacerbations. It was there, but was it clubbed with this inherited point? Was that inherited point was clubbed with chronic intravascular hemolysis with frequent exacerbation? Perfect. Thank you, guys. Inherited disorder with chronic intravascular hemolysis and frequent exacerbations. Obviously, that becomes wrong. Frequent exacerbations is never inherited. It's always acquired. Okay. All right. Then still our answer remains A. It is flow cytometry is the gold standard. So are you guys sure that sucrose lysis test was useful for diagnosis was there, or is there anything else that we can modify this statement? Sucrose lysis is useful for diagnosis or something else was there? I'll come back to the randoms. 33 out of 40 is a very good number, honestly, with this paper. Suicidal patient, chlorpheniramine toxicity, I don't believe. No, that's not correct. I mean, what was the exact option? Sucrose lysis test is useful for diagnosis, or what was the question, by the way? What are the exact option? Now all four options same. Still, I'll go with A. Okay, all right. This is done. I think somebody was asking about reliable test for diagnosis was the exact line. Thank you. It's not a reliable test. Okay. Thank you. Thank you so much. It's complete. 26 out of 39. Good number still. Alzheimer protein. Yes, somebody was asking about Alzheimer. It's A beta amyloid. Was there A beta amyloid on Alzheimer? Right atrial collapse with pericardial effusion. Yeah, in simple pericardial effusions, we don't see right atrial collapse. We see right atrial collapse only if there is an associated tamponade. I don't know, thousands of times we have discussed. I mean, I'm not demotivating the other guys like who have not attended the classes, but still we have discussed that plenty of times, thousands of times. RARV collapse is a classic feature of tamponade. Yeah, Alzheimer disease protein, it's A beta amyloid. Okay, all right. Okay, fine. Intrinsic pathway. What was the question on intrinsic pathway? Alzheimer means A beta amyloid. That's it. It's very, very, very important.